Hello and good morning to everyone. So today's topic is pain. It's pathophysiology and management. It is going to be totally Harrison based, 22nd edition. And don't worry, we are not going to leave even a single line from Harrison's. It is going to cover length and depth from this chapter, and it is particularly important that we start from pain because it is the first chapter in Harrison's cardinal manifestation section. So we'll see how it is defined. As per Harrison's, it is defined as an unpleasant sensation localized to a part of the body. Its pain is to protect the body and maintain homeostasis. So, how are we going to get protected by pain? By detecting, localizing, and identifying potential tissue damaging processes going on in our body. So, whenever a patient presents to us, maybe say chest pain or pain in abdomen or headache, this is the common mnemonic or common dictum that we used to generally use in our clinics so that we don't miss out any point. So it is Socrates. S stands for the site of pain, O stands for the onset of pain, C stands for the character because pain can be stabbing, can be dull aching, can be squeezing in nature. So the nature, the character of the pain is to be asked. Radiation, if any. Most commonly, the pain of myocardial infarction radiates to the left arm and the left and the jaw. Then associated symptoms. Pain associated with diaphoresis, pain associated with breathlessness gives us many differential diagnoses. Hence, associated symptoms are also important. Then the temporal evaluation. How the pain is the pain static? Is the pain progressive in nature? Then exacerbating and relieving factors. Whether the pain is getting relieved by medications or not. And lastly, severity. Though objectifying severity is quite a task, but we can ask the patient to scale it from 1 to 10. If the patient is in agonizing pain, he might tell you that he is giving 9 out of 10 marks. So that means you have to act promptly and consider the pain and act swiftly. So the whole point why are we discussing pain is pathophysiology. So there are two mechanisms. One is peripheral mechanism and the second is central mechanism. Peripheral mechanism has primary afferent nociceptors. The second part is sensitization. The third is nociceptor-induced inflammation. And the central part has spinal cord and referred pain, pain modulation, and neuropathic pain. So don't worry about these terms. We are going to decipher it layer by layer. So the first thing is primary afferent nociceptors. Before understanding what is primary afferent nociceptors, we must understand what is a peripheral nerve consists of. So let me go and highlight. Um, so as we can all see, this is a spinal cord section in which this is the gray matter, this is the white matter. From the gray matter, there is this peripheral nerve which is originating, and peripheral nerve consists of these three distinct axons, these three distinct nerves, and they are labeled as A beta, A delta, C, and there is this another unmyelinated. So basically, we are identifying this peripheral nerve on the basis of its myelination. So this looks large and it is myelinated. Whenever a nerve is large and myelinated, it is useful for fast conduction. So in our body, there are two things which needs to be very fast. The first one is motor system, and the second one is the dorsal column pathways that are our joint sense, vibration sense, position sense. So these things must be rapidly transferred to the spinal cord and via the spinal cord to the brain. Hence, these A beta fibers, which are large and myelinated, are responsible for light touch, vibration, position sense. But as far as pain is concerned, pain is a sensation and hence sensory system. This A delta and C fibers. A delta is small in diameter but it is also myelinated. A delta fibers are responsible for pain conduction. It takes pain from the periphery towards the spinal cord. Also, the C fibers you see here, these are small fibers and they are unmyelinated. They are also responsible for carrying your pain sensation. Hence, whenever we say that pain is being conducted from the periphery to the spinal cord, we must tell that there are A delta and C fibers. A delta means small diameter, myelinated. C fibers are small diameter and unmyelinated. And one more thing, this sympathetic ganglion and there is this post ganglionic sympathetic fibers. They are also small fibers. They are also termed C fibers. Okay, so these fibers, A delta and C fibers, are present over the skin, deep somatic tissues, and viscera. Therefore, A delta and C fibers are considered as primary afferent nociceptors. Do you guys understand? So, the thing that is required for the pain to get conducted is these two things, A delta and C fibers. So, but actually, the word nociceptors are the receptors that are. So, if you follow this A delta, wait a minute. So, if you follow A delta fiber, it may be ending up in a skin of your right arm that acts as a free nerve terminal, nerve endings. That nerve ending acts as the nociceptor. Okay, and these nociceptors respond to noxious stimuli. So, what are the noxious stimuli? It is so natural that it is heat, intense cold, mechanical trauma, such as like if I pinch on a person's hand, the patient feels pain. So, that conduction from periphery to the spinal cord is taken care by the A delta and the C fibers. But keep that in mind that A delta fibers take fast pain and C fibers take slow pain. As we all know, that myelination denotes the velocity of the conduction. Whether the nerve is myelinated, there will be fast conduction. So imagine for a minute that you're walking on a road and you stamp on a stone. Your great toe gets hit by a stone, and there is a sense of rapid pain, rapid intense pain. Yes, exactly. That is carried by the A delta fibers. But then you wait for a while, console yourself, and start walking. Then, while walking, also there is continuous, slow, dull, aching pain associated with that great toe, and that, my friends, that is with the help of the C fibers. So, any these noxious stimuli these noxious stimuli are going to activate the A delta and the C fibers. Okay, and then any chemical irritants, serotonin, bradykinin, ATP, histamine, and any change in the pH can activate our primary afferent nociceptors. So our first thing that primary afferent nociceptors is done. The second thing is sensitization. But first, understand the terminology sensitization. Sensitization basically means that our injured great toe is now imagine now we got hit by that stone on our great toe. If by chance somebody stamps on our foot, what will happen? We'll again have so much pain even if somebody just touched it. So that means that area became sensitized. That means it is now easily getting excitable. Even on touching, even on slight painful stimuli, that area is getting excitable and sending pain signals to the spinal cord. Okay, so it is just that when repetitive, prolonged, and intense stimuli is given to a damaged or inflamed tissue, inflammatory mediators such as bradykinin, nerve growth factor, prostaglandin, and leukotrienes are recruited, and they increase the excitability of the nerve terminals, leading to sensitization. The best example of sensitization is when you have a sunburn. Maybe you spent a lot of time in hot, humid sun, and there is a sunburn on the skin, and you pour cold or hot water on that burn. Maybe that hot water was warm only, not that hot, but still you will feel extreme agonizing pain at that region. Hence the term sensitization. So there are certain different terminologies associated with sensitization. The first is allodynia. The first is allodynia. Allodynia basically means even with non-noxious stimuli, the person feels extreme pain. The second is hyperalgesia. With mild noxious stimuli, the patient feels agonizing pain. Then there are terms like tenderness and soreness. So these are basically terms related with sensitization. So examples such as sunburned skin, warm shower, herpes zoster patients. If you have seen them, the herpes zoster affects the dermatome, and on even on touching the dermatome, the patient feels agonizing extreme pain. That term is known as allodynia, which we have discussed here. So, talking about the viscera now, as till now we were talking about A delta and C fibers, which were um, supplying the periphery, the skin, and the deep somatic tissue. But what about the viscera, the hollow viscera? A large proportion of uh, A delta and C fibers afferent innervating viscera are completely insensitive in normal, non-injured, non-inflamed tissue. That is, they cannot be activated by non-mechanical or thermal stimuli and are not spontaneously active. However, in the presence of inflammatory mediators, these afferents become sensitive to mechanical stimuli. Such afferents have been termed silent nociceptors, and their characteristic properties may explain how, under pathologic conditions, the relative insensitive deep structures can become the source of severe and debilitating pain and tenderness. So basically, our viscera also, under inflammatory mediators, become a source of severe and debilitating pain just with the help of these A delta and C fibers. Again, everywhere you sense pain, blame A delta and C fibers. As far as they are intact and in position, they are going to transmit pain. So this was all about sensitization. The third thing is nociceptor-induced inflammation. So till now we read that A delta and C fibers are our primary afferent nociceptors. So we thought that they are the only playing just the transmission part, like they are the mere messengers. But no, they are not mere messengers. They also contain polypeptides within them. So whenever these nociceptors are activated, they release certain polypeptides such as substance P, cholecystokinin, and calcitonin gene-related peptide. These substance P, cholecystokinin, calcitonin gene-related peptides leads to local inflammation. Hence, it is termed as nociceptor-induced inflammation. We'll see in the image part that this is a normal skin, but when there is injury, primary activation, the cells die. There is release of potassium, uh, uh, pH, lowering of pH, prostaglandins are released. This primary activation sends signal transduction, and this signal goes to the spinal cord. That much we know. But in in secondary activation means that after that signal has gone, there are also certain things like this activation leads to activation of the neighboring nerve terminals. With the help of the substance P, there is dilatation of the blood vessels, increasing its permeability, releasing bradykinin. Also, this substance P degranulates the mast cells, releasing of histamine, releases serotonin from the platelets, and hence ultimately leads to inflammation. So basically, in peripheral mechanism, till now we have learned that there are primary afferent nociceptors, which includes A delta and C fibers. A delta are small diameter but myelinated, which carry fast pain. C fibers are unmyelinated and small fibers which carry slow pain, and they are termed as primary afferent nociceptors. They are our free terminal ends. The second thing we learned is sensitization, that the area gets sensitized with the help of inflammatory mediators. And again, the third thing which we learned is nociceptor induced inflammation. So these are the three mechanisms. Now we move to the central mechanism, how the pain is actually perceived, how the pain is actually perceived by the brain, how it is transmitted. That thing we are going to learn. So as this image is given, this is a viscous, hollow viscous, it can be anything, and there is the skin. From that, we have our primary afferent nerve fibers. Call it as A delta or C fibers, okay? Any of them. They have their cell body in the dorsal root ganglion, and they end in the dorsal gray horn. So this fish here, you see, the first neuron, that is our primary afferent neuron, ends here. Then the second spinal neuron starts. It crosses the midline, goes to the opposite side, lateral side in the white matter, and travels upwards. Okay, so basically, as we have learned in our physiology classes, there were spinothalamic tracts which carry pain and temperature sensation, correct? And there were dorsal column sensations. Dorsal column means this part. Dorsal column sensation which take light, touch, vibration, proprioception. But in this context, we are not concerned about this dorsal column pathway. We are concerned about this spinothalamic tracts. So spinothalamic tracts carry the sensation, they cross in the midline, and they go upwards. Okay, so what I had told you, that this synapse is the main thing here for rapid conduction. So for rapid pain, the neurotransmitter released here is glutamate, and for the slow pain, which is transmitted by the C fibers, the neurotransmitter uses a substance P and calcitonin gene related peptide. Okay, so we'll come to this referred pain much later. Now, as we have again see this image A, so there is injury, the pain sensation is being transmitted, the first neuron ends here, the second neuron starts, crosses the midline, and now travels upwards to the thalamus, because this tract is known as spinothalamic tract. starting from the spinal cord to the thalamus. Okay, but this spinothalamic tract runs laterally. So it moves upwards, lateral medulla, lateral pons, lateral midbrain, ends in the thalamus. So here the spinal neuron ends, its synapses, and the third order neuron starts. It is so this neuron which starts from here, it goes and supplies the somatosensory area, the sensory cortex, which is the prime location for identifying, localizing, and identifying the intensity of the pain. So, whenever there is a pain, say for example, if I pinch you, you immediately come to know that I have pinched you on your right arm. It is severe. I have pinched you so hard, and it is going to trouble you. So, basically, identifying, localizing, and how much the pain is in intensity is basically known by the somatosensory sensory cortex. But also, you may have known that pain comes with there is duality in pain, meaning pain has a sensory component plus an emotional component. Whenever there is pain, the child starts crying, the child shouts aloud. Okay, so from thalamus some fibers go to this anterior cingulate gyrus and also the frontal insular cortex, which are concerned with the emotional part. Hence I must write here that there is duality, meaning there is a sensation part and there is emotional part to it. Okay, so this was whole ascending path. Primary efferent nociceptor, primary efferent nerve, ends here in the dorsal gray matter horn. The second neuron, spinal neuron, starts. It runs laterally, spinothalamic tract, taking the pain and temperature sensation, lateral medulla, lateral pons, lateral midbrain, ends in the thalamus, and from the thalamus, some fibers reach the sensory cortex and some fibers reach the cingulate gyrus and the frontal insular cortex. So then the next thing is pain modulation. So, as in the beginning only, I had told you that pain is a subjective experience, a subjective sensation. That maybe that in different situations, the person feels pain differently. So, for example, an army veteran or an army officer during a war, if he is hit by a bullet or if its leg gets fractured, even though he doesn't stop, even though he keeps on fighting. On the other hand, a person who is admitted in the hospital, a simple procedure as a veiny puncture, inserting a cannula in must may be agonizing for that person. Hence, the pain produced by injuries of similar magnitude is remarkably variable in different situations and in different individuals. So, basically, what I'm trying to say is there is a psychological and emotional part attached with pain. So, Harrison says that even the suggestion that this treatment will relieve pain can actually induce analgesic effect. And on the other hand, a suggestion that this treatment will not, is going to increase your pain, and it actually increases the pain in the patient. It is a nocebo effect. So it says that there is a powerful effect of expectation and other psychological variables on the perceived intensity of pain is explained by the brain circuit that modulate the activity of brain. So that is what is explained in this image. They think, as per Harrison's, there are pain modulatory descending pathways. So starting from frontal cortex, midbrain, medulla, and ultimately to the area where the primary afferent nerves synapse with the spinal neuron of the spinothalamic tract. Do you guys remember? This is a spinothalamic tract running laterally, ultimately reaching to the thalamus. Okay, so these natural pain modulating fibers are descending in nature. They synapse at multiple levels and they ultimately can even reduce or even enhance the pain. Okay, this is with the help of opioid, natural endogenous opioid peptides such as enkephalins and beta endorphins. The most reliable way to activate this endogenous opioid mediated modulating system is by suggestion of pain relief or by intense emotion directed away from the pain causing injury. So, suggestion or an intense emotion directed away from the pain causing injury. Maybe tell if somebody is in pain. I don't know, I haven't tried it, but if somebody is in pain, make sure he's diverted from that pain. Okay, make him remember his girlfriend, make him remember about something different altogether from this situation, and might this might help because it releases enkephalins and beta endorphins, which acts on the pain modulatory pathways. Okay, and the third thing is neuropathic pain. So now tell me, if if this is the whole pathway, if this is the whole pathway, this is how the pain is transmitted. If I have a, say here, if I have a stroke, if I have lateral medullary syndrome, what do you think, what is going to happen with the patient? The patient will have contralateral loss of pain and temperature. The patient will not have pain and temperature sensation in the contralateral side of the body, right arm and right leg. There will be complete loss of pain and temperature if this is cut off. So that is one thing. But these peripheral nerves, remember they were myelinated. So there are certain conditions in which the peripheral nerves gets demyelinated or they are injured. As example being diabetic neuropathy, example being leprosy. There are several examples in which the peripheral nerves gets affected, and hence it is not completely cut off, but this nerve is not completely cut off, but it is damaged. Hence the patient perceives pain such as burning sensation, tingling sensation, electric shock like spontaneously, either spontaneously or with light stimuli. Okay, so this was all about pain. So this is how we have completed with pathophysiology of pain. Thank you.